Hello, good evening, everyone. My name is Catherine. I am a clinical lab consultant with Wave, and thank you for joining our webcast this evening. Tonight, we are excited to have Dr. Hawkin Lui joining us, and tonight he'll be sharing several practice pearls for building a successful myopia management practice, including going over some tools used for patient education and staff incentives and development. There is a chat box on your GoToWebinar screen where you can enter questions. Please feel free to enter those as they come up during the presentation or immediately after. And then we should have a few minutes to go over those at the end with Dr. Lui. And again, we're happy to have Dr. Lui joining us tonight. He is the owner of Optometry Corner in Irvine, California, where he specializes in fitting specialty contact lenses for hard to fit cases, as well as fitting ortho K lenses for myopia management. Prior to moving to Irvine, Dr. Lui worked in a medical optometry practice in Central California, where he provided eye care to patients with glaucoma, diabetic retinopathy, age-related macular degeneration, and other eye diseases. So thank you so much again, Dr. Lui, for your time and being here this evening. And with that, we can go ahead and start the presentation. Thank you.
Hi, my name is Hawkin Lui, and today I'll be presenting the pearls and practical tips for building a myopia management program. My contact information is underneath here, so you can feel free to reach out to me should you have any questions about the presentation or just to reach out to say hi. I'm open to communicating with everyone on this call, on this presentation. So a little background about myself. I graduated from UCLA in 2007. I went to Berkeley for optometry school and graduated in 2012. And one of my classmates' father was retiring from his practice, so I acquired a practice and started Optometry Corner in 2016 in Irvine, California. In 2018, we started fitting patients with specialty contact lenses, and I started with designing center distance contact lenses to reduce myopia in children and teens. Then 2020 happened, and the pandemic happened, and it shifted everyone's vision from in the classroom to working from home. And during this time, there was a lot of increased indoor time, increased screen time, and we were seeing patients and children's myopia increase quickly. In 2021, I became a dad. And when I became a dad, it became apparent to me the importance of myopia management. And so I also hired 2 associate optometrists to help, and so that we can practice our passion for myopia management. And in 2022, I had visited Seattle. It was in Bellevue, Washington for the Vision by Design. That was an awesome conference. I recommend that to anyone who hasn't been to Vision by Design. And that's where I first met the Wave team. Wave is gracious enough to sponsor this talk, this presentation. And I was very impressed by the Wave team, by the Wave software, and by the tools that Wave has created to allow us to manage myopia in children. This is a picture of my family and my daughter. This was taken at the Seattle Children's Museum in 2022 when we visited for Vision by Design. Becoming a father led me to think about myopia and how it is progressing in the entire world. I am one of 4 children, and every one of my siblings has myopia. And I have the worst myopia. I was a -7 with a 125 astigmatism prior to doing laser eye surgery. My wife is a -4.25 with 1 diopter of astigmatism. So currently our daughter does not have myopia, but I am monitoring her eyes carefully because genetically she's at risk for developing myopia. So the overview of today's presentation will be why do we provide myopia management services and the tools that we use to educate patients and staff and also parents on myopia. We support staff. We have a support staff as well. We develop this. It's important for us to develop our staff as well as incentivize them properly. We will also touch upon chair costs and cost of good analysis. At the end of the presentation, I'll be happy to answer any questions that we have. So let's get into the why. The why for myopia is why do we provide this service? What is it about myopia that is so important for us to manage or control? Myopia is an epidemic. It is a pandemic, and it's growing really rapidly. Currently, in the year 2020, there was 34% of the population that has myopia. That's 2.6 billion people in the world, but this is increasing rapidly. Some studies suggest that the rate of myopia is increasing at 2.5 to 4 times faster than pre-pandemic levels. And we are seeing that in our clinic as well. We see some children that are advancing very quickly. They may be a -1 last year, and the next year I see them, they're a -3 or a -4. And it's increasing so quickly that it's startling. The average screen time has increased pre-pandemic as well, from 9 hours a day to now 13 hours a day for many patients. I'll ask them, one of the first questions I ask them is, how much time do you spend on the screen? And they look at their phone and they check their screen time and they're like, well, it looks like yesterday I spent 12 hours or 13 hours, or some cases 16 hours. We're either looking at a computer screen or our phone all the time. And we all have seen this statistic already. By the year 2050, the global trend is predicting that 50% of the world's population will be diagnosed with some degree of nearsightedness. 50%. And this is the first time in human history that there will be more myopic eyes than hyperopic eyes in the world. Think about that for a moment. In the entire evolution of the human species, this is the first time in our history of evolution that there's going to be more nearsighted eyes. Why does that matter? Because in certain parts of the world, children are struggling in school. They're facing myopia at an epidemic level. In China, there are metal bars that are put up to reduce the rate of progression, to try to reduce myopia progression in children by extending their viewing distances. By high school, in places like China, Korea, Singapore, 80 to 90% of the population is nearsighted by the time they're teenagers, by the time they enter high school, which is quite startling. And we all know that with the level of myopia, there is increased risk for eye diseases, many of which can cause blindness, including myopic maculopathy, retinal detachment, and glaucoma. The more myopic the eye becomes, the higher the risk for eye diseases, many of which could lead to blindness. Retinal detachment, for example, over -6 diopters or over 26 millimeters in axial length, increases the risk for retinal detachment by 21.5 times. And if it's -8, this causes the risk for retinal detachment to increase to 44.2 times higher than an emmetrope. And we see glaucoma here in our office as well. And glaucoma, we often see it in high myopic patients. I just saw one this morning, a -7 or 8 patient with gross myopia, very severe myopia because of vertically extended long eyeball. And myopia leads to a thinning of the retinal nerve fiber layers, which causes glaucoma. So education, we start with education. That is very important. We educate our patients on what myopia is so that they understand that it is an eye disease that could lead to many eye diseases. It is an eye disease that could lead to other eye diseases that lead to blindness. So we educate patients using specific tools at our disposal. We have optometry equipment, of course, and we use bookmarked pictures in Google, and we bookmark it on our Google Chrome so that we can click on the button and show pictures of myopia. That helps us educate patients and their parents on what myopia is. There are other online tools that we use, including the MySight Myopia Simulator, that we can demonstrate to parents what myopia looks like for their child. And we also utilize the Brian Holy Vision Institute Myopia Calculator, allowing us to have a trajectory and calculate myopia worsening over time. And we print the copy for the parent so that they have something that they can go home with that is directly related to their child's myopia. So the optometry equipment that we use, this is the picture of our pre-testing room. When the parent comes in with their child, the parent is standing next to their child, and we check the child's eye, and usually the parents are patients of ours as well. So that really helps. So we check the child's vision, then we sit them down in the pre-testing table and we take the axial length of the child. We measure the axial length and the topography for every child that is under the age of 12 or under. And we do this so that we can get a baseline of the axial length, while at the same time allow us to have a conversation with the parent and the child in the exam room about myopia. This instrument is the Oculus Pentacam AXL, and it is the wave version, so it allows us to capture images of the topography and to custom design orthokeratology lenses for our patients. It also has an ophthalmic biometer to allow us to measure the axial length of the patient. We just got this device about 4 months ago, and we're performing this test on all of our patients under the age of 12. In the exam room, this is the view of our exam room from the parent's perspective. When they sit down in the chair, the child sits down in the chair, and the parent is sitting on the side. They could see the child, they could see the visual acuity chart, and they could see our computer monitor. We use the computer monitor to educate the parent and the child when they're sitting in the chair. It opens up the conversation. So we bookmark photos on our Google Drive, and we organize it in these categories: refractive conditions, anterior cornea and lens, and posterior retina. So this allows us to have this conversation. We pull up an image, whatever the patient is mentioning, the reason for visit. They might say, oh, I saw this glob or this blob that was in front of my eye, and it disappeared after 15 or 20 minutes. What was that? So we'll show them pictures of an ocular migraine, and they'll say, yes, that's what I see. I saw that yesterday, and it freaked me out. And these pictures are worth 1,000 words, because when we explain it in words, it's difficult to explain what ocular migraine is. It's difficult to explain a retinal detachment, what that looks like. It's also difficult to explain what astigmatism looks like. So when we show them these pictures and we say, if you see this, these are red blood cells in the vitreous, and this means that there's a retinal detachment, that there's a retinal tear in the eye, and there's a vitreous hemorrhage. And they'll say, oh, okay, so there are floaters here, and then there are vitreous hemorrhage red blood cells. It also allows us to explain astigmatism. Especially for children, they don't know what astigmatism is. They think that this is normal. So we'll show them a picture of astigmatism, and they'll say, yes, I do see that. I see streaky lines coming out of the headlights from the car. They think it's normal. And we tell them, no, that's not normal. That is astigmatism. And we could correct it with corrective lenses, whether it be glasses or contact lenses. Now, these pictures on Google Drive is very helpful. I would encourage everyone watching this presentation to create a gallery of images that allows us to educate our patients better about myopia, about the risk for myopia, about orthokeratology. So this is a snapshot of our Google Drive photos. Now, what is very important about it is what we do is we show pictures of the patient's eye, and we show pictures of their OCT. We tie it back to the patient. So we take a picture of their OCT, for example, and we demonstrate that light bends around the cornea and light bends around the lens of their eye. And when it bends, it focuses on the fovea. Then we show them that if they have normal eye or a myopic eye or a high myopic eye, the more myopia there is, the further away the focusing of the light is from their eyeball, and the blurrier it is. So we show patients and their parents a picture of their retina, and we say, well, the light is not landing on the fovea, it's not landing on the macula, it's landing in front of it, about 1 millimeter in front of it for every 3 diopters of myopia. And so what we say is that we can correct it with glasses, and that brings the light further back, so it lands on the fovea. But what we could also do is flatten the fovea with a orthokeratology lens. So we'll show them a picture of their cornea, and we'll say the lens will flatten the front of the cornea and flatten the front of the eye in order for light to bend, and that will allow light to land on your retina. And so therefore, you'll be able to see clearly with the orthokeratology lens. And we also tie it back to the patient by showing them what a expected axial length is for an emmetrope and what their axial length is. And using the Pentacam AXL allows us to measure their axial length and confer, basically compare it to the axial length measurement of the expected emmetrope. So these pictures allow us to explain what an eyeball looks like, what it looks like with the focal point is in front of the retina, And how blurry it gets, the further the focal point is from the retina, the blurrier the patient sees. So what if the patient and the parent, what if the parent doesn't have myopia and doesn't know what the child sees? There are online tools that can simulate what myopia looks like. And that's the website for the MySight simulator. There's also the Brian Holden Vision Institute myopia calculator, which we use daily to demonstrate and calculate the level of myopia that the child will have when they become 17. So this is the Brian Holden Vision Institute calculator. You can take a snapshot of that, and I encourage visiting that and using that as a resource for your myopia consultations. Now, the myopia simulator is also one of the tools that we use. If the child is emmetropic, or the parent is, they don't know what myopia looks like. We can demonstrate precisely what a -2 looks like to the child. And I often ask the child, where do you sit in the classroom? This is a great tool to show parents what their child sees in the classroom. So if the child says, I sit near the back, oftentimes the child does not realize that they see blurry compared to their classmate. So we show a -2 on the vision simulator for MySight, and the parent says, oh wow, oh no, my child is seeing blurry in the classroom. That's not good. We also show what it looks like in the gym with myopia, and we can use the simulator to simulate different levels of myopia from a -1 to a -250 to a -4 or a -6, and it gets blurrier with and the patient and the parent realizes what their child is seeing. Now, another way to do it is to get accommodative flippers or a trial lens holder. And we have flippers in our exam room that are of different powers. That's a picture of our accommodative flippers, color-coded with different powers. And we'll put the -2, for example, in front of the child's eye, and the child will say, wow, I see so much better, because they're a -2 myope. And they didn't realize that they could see a lot clearer. Then we flip it around and we show a +2 to the parent. And we say, well, this is what your child sees with the +2. And the parent goes, whoa, that's terrible. And when we show the child the -2, they're like, wow, that looks really clear. And that's the aha moment for both the child and the parent. That's when they realize that they need to do something about it, that we need to do something about it as their eye care provider and reduce myopia. The -2, it doesn't stop there, because if that child is only 6 years old and they're a -1, they will progress to a -7 by the time they're 17 years old. So we use this calculator on a daily basis called the Brian Holden Vision Institute Myopia Calculator. It's a free tool online, and it's been very useful for our practice. This is orthokeratology. We use it to simulate what orthokeratology could do for the child, how it could reduce the level of progression of myopia in the child, and we use it every day. Orthokeratology, we can adjust it. So it has other tools that we could use as well. It's not just for orthokeratology. We could simulate soft multifocal contact lenses. We could simulate progressive addition spectacle lenses. We could simulate low-dose atropine, or even medium-dose atropine, or high-dose atropine, or combined treatment. So these are based on peer-reviewed control rates. 70, sometimes 80% control with a combined treatment if we do orthokeratology with atropine. And this charts out what myopia progression would look like for the child if we were to just continue with glasses every year. If the child is 6 years old and they're -1, they're coming to us and with a slightly blurry vision. By next year, we could expect it to be a -2.5 if we don't slow down the myopia. However, if we were to start with orthokeratology, they would only be a -1.5 next year, maybe even only a -1.25. But over time, that's when it makes a significant difference in the level of myopia and a significant difference in the axial length of the child. About 3 out of 4 eyes slow down and stop growing by the age of 17. But that means 25% is still progressing beyond age 17. We can compare not just orthokeratology, but also multifocal soft contact lenses. So with a specific lens, we can prescribe multifocal soft contact lenses and control myopia progression by 59%. So by dialing in 59% control rate, we can show the parent and the patient what their overall level of myopia would be by the age of 17. And in this case, the child would be a minus 3.46 if we started them with a lens such as MySight or Natural View multifocal, or like a Biofinity multifocal with a center distance design. So would they rather be a minus 3.46 or would they rather be a minus 7.01? We can demonstrate the difference using the myopia simulator and show the parent and the child what they would look like if they were to be minus 3 versus a minus 7. Or if they were to do orthokeratology, it would be a minus 2.8 instead of a minus 7. So these have been very helpful at educating parents and the child about the overall risk for myopia and how now with technology we can slow down myopia progression in the child. There's also different languages that this is available in Spanish and Chinese, different languages. And it's very tailored to the patient, whether they're Asian or Caucasian. There's different peer-reviewed studies on showing myopia progression based on ethnicity and age and the myopia management option. Now, after having a discussion about the trajectory of myopia, what is the solution? The solution, 90% of the time, we ask the patient to try on the Ortho-K lens because we know that that has better results. So I have sample Ortho-K lenses in our office that we put on the patient to see what their reaction is. Depending on the reaction, we go from there. If the child doesn't even flinch when we put an Ortho-K lens in their eye, then we know that Ortho-K will work for that child. But if they're crying and fighting and pushing my arm away when I'm putting the Ortho-K lens in their eye, then we might want to try something else first and advise the parent that maybe Ortho-K is not the right time for them this year, but we can try again next year, or maybe we could try again in 6 months or 3 months. And it really depends on the comfort level of the patient. But what I'll tell the patient in the chair is, this is the least comfortable that the lens will feel on your eye. I don't use any anesthetic on the eye. We put the Ortho-K lens on the eye without any anesthetic, and the child will close their eyes, and I'll say, imagine if your eyes were closed and you're sleeping, and your eyes would be closed the entire time. When you wake up, you take out the lens and you'll see better. Like, how does that feel on your eye? And depending on the patient's response, we'll know at that point whether they will be successful with Ortho-K this year, or if we have to delay it for 3 months or 6 months or 12 months before we can fit them with Ortho-K. I'll also put some fluorescein strip on their eye. I'll use a fluorescein strip and put some saline on it and put it in their eye and glow with a blue light, a small little LED blue light. I'll glow the Ortho-K lens on the child's eye so that the parent can see it on their child's eye. And they envision that's what it's going to look like when the lens is on the eye. It also helps me explain what the lens is doing in flattening the center of the cornea. So we show and tell. We actually put the lens on and we show the parent and the child what it looks like and why we're doing it. So all of this is important, but we need a team to be able to implement this. I'm just one person and I cannot do it all by myself. So we have an entire staff that helps promote myopia management. We also have a virtual healthcare assistant here that helps us tremendously with our myopia management implementation of the program. And we walk the walk and talk the talk. If we say outdoor time is important, then we go outdoors and have fun together. This is us at a recent team bonding event at Legoland. We went out together on a day off just to be outdoors and to spend time with each other. So teamwork makes the dream work. We encourage outdoor time for our parents, or for our patients and their parents, and we also encourage outdoor time for ourselves. We have lunch meetings. This is where we talk about myopia, and we have weekly meetings every week where we keep track of how we're doing with the myopia management program. We track progress. We have a chat group dedicated specifically to myopia management that we discuss patient cases with. It does start with communication, and having lunch meetings, weekly meetings, allows us to increase our communication among the team, which allows us to provide better care overall. what I encourage offices to think about is how do we incentivize our staff to implement myopia management. One of the things that I found helpful is incentivizing the entire office on implementing myopia management and not just one individual, or also not incentivizing individual opticians on selling glasses, for example, because that would actually be contrary to doing orthokeratology or contact lenses. We want to encourage patients to explore other lens options besides glasses, and if we're spiffing or incentivizing certain opticians to sell glasses, that would be contradictory to fitting a child with orthokeratology lenses. They would want their child, we want children to wear ortho-K lenses and not spectacles. So let's go ahead and incentivize the entire staff for doing a team job and a team effort in implementing rather than individual incentives. So the next part of the presentation, I will be discussing chair cost and cost of goods analysis. How do we implement myopia management cost effectively in our offices? It all starts with setting our fees appropriately, and setting our fees appropriately means setting our fees at a level where we can continue to provide care to the patient for the next 10 years. If the child is coming to us when they're 7, 8, 9 years old and they're starting to develop myopia, we could expect to see that patient when they're 16, 17, 18 years old or even older when they go on to college. We have some patients that are college age that are wearing ortho-K lenses. And as we do this, 10 years down the line, we need to make sure that we're delivering care effectively, but also staying profitable in that process. So we could be around 10 years from now and continue to provide that high level of orthokeratology and myopia management services to our patients. So this is an example. These are not actually my prices, but this is an example of the cost to deliver care for myopia management, taking into account chair cost time and cost of goods time. So to deliver ortho-K services to the patient, that takes about 4 to 5 hours a year when we start. It takes into account the demonstration of the lens, the training of the lens, the parameters of the measurement of their axial length and their topography scans, and all of the follow-up care and the redesigning of the ortho-K lens if that's necessary. The time it takes to design the lens, redesign it, and teach the patient how to use ortho-K themselves, about 4 to 5, sometimes 6 hours for the first year. But by the second year, that cost of chair time reduces significantly because the child already knows how to put on and take out the ortho-K lens. So then we just follow up with pre-testing and we see what their axial length measurement is and we see what their topography scans look like. And each subsequent year, year 3, 4, 5, it only takes about 1.5 hours per year for the child. So our chair cost time, depending on where you are, we're in Southern California and it's quite expensive for rent. So our numbers are a little bit higher than this for chair cost time. But on average, let's say it's $200 or $225 per hour. So the chair cost time for ortho-K, for example, would be $900 for the first year. And the cost of goods for the ortho-K is roughly on average $300 for a pair of ortho-K lenses. So the total cost to deliver care would be $1,200 for ortho-K. And if we use that same metric for soft multifocal contact lenses, it would cost us about $1,175, which is close to $1,200. So when we take into account chair cost time and cost of goods of materials, it's roughly the same. For atropine, we're in California, and as optometrists in California, we do not dispense atropine to patients. So the patient brings the atropine to a compounding pharmacy, or we connect them with a compounding pharmacy to get their atropine. So we're not actually delivering the cost of goods for atropine. That's why it's $0. But there is still that chair cost time to use our equipment, to gather data, and to review it with the patient and the parent. So this is a cost of goods analysis, taking into account the chair cost time to deliver the care to the child. Over time, we can see that the cost increases year after year. So I encourage us to think about myopia management as an investment. Why is it an investment? Because when we set our fees appropriately, and this is again an example of professional fees for myopia management, this is not my actual fees. Over time, the cumulative cost for the parent is going to increase over time. So these are like an example of professional fees for myopia management. If we were to implement Ortho-K, if the child does Ortho-K every year, they will end up paying less than multifocal soft contact lenses, but they're roughly the same. Over a 10-year trajectory, the cost to deliver care is about the same because of chair cost time, but also the patient's fees for myopia management is about the same as well. So if the child were to go with Ortho-K versus multifocal soft contact lenses, we could see that it does start to diverge, and it's a little bit more expensive to do the combined therapy. But Ortho-K and multifocal lenses, because they're close enough, we use the same price. We have the same price whether we are delivering multifocal soft contact lenses or orthokeratology, because simplicity is best. It's easy to make things complicated. It's difficult to make things simple. So we have a simple fee structure where we have one fee for myopia management. And whether it's more suitable for the child to go with Ortho-K or multifocal soft contact lenses, we have the same price. We also provide flexibility in the payment, so patients can pay all at once or they can pay monthly. But the important thing is to set our fees appropriately so that patients can benefit from our care and from the practice. And the goal is to take a long-term view, because ultimately we do want patients to be wearing Ortho-K if the timing is right. They may start with atropine in the beginning, and then they wear atropine with spectacle lenses, and then they graduate to a soft multifocal contact lens. After that, they'll graduate to a Ortho-K lens if it's suitable for the patient. We do allow patients to switch between multifocal soft contact lenses to Ortho-K, and usually what I find is the parents want them to switch to Ortho-K sooner. And the child, they're not as comfortable with Ortho-K yet because it doesn't feel as comfortable. But we can fit them with multifocal soft contact lenses to begin with, and after just 2 weeks, 3 weeks, 4 weeks, the child is a professional. They're a pro at putting on the soft lenses. Then they're more open to Ortho-K. That might just take 1 month. And during that time, we give them trial lenses for 1 month of multifocal soft contact lenses. So it's not any cost of goods associated with that. And then we order the Ortho-K lens, and 1 month later, the child is putting on the Ortho-K lens themselves without any issue. So children and kids especially, they adapt very quickly. And it's the anxiety of the idea of having a hard lens overnight that it's more mental than it is physical. Once they get over that mental anxiety, they're able to put in the lenses very easily, and they do it themselves. So we kind of hold their hand during that process, and we do what is right for the patient's age. Now, all of this, back to fees, it does take a lot of balancing, a lot of organizing with myopia management patients. So our office, we have a Google spreadsheet, an Excel spreadsheet that has all of our myopia management patients, their age, the last visit, whether they are using orthokeratology or a specific multifocal soft contact lens or atropine, what they have paid, whether they're doing a one-time payment or whether they're doing a monthly payment. And so every situation is different. It does require being organized to keep track of that. And we have a myopia management coordinator that keeps track of all of this. Whether a monthly recurring payment doesn't go through, then we call the patient and they'll give us another credit card information over the phone, and then we add it on and we continue to bill them monthly for the myopia management services. It also allows us to reach out to patients that missed a appointment or are overdue for a renewal, and therefore we are able to get our patients back in and continue the myopia management services that we provide. It does take a lot of coordination, so it's helpful to have a coordinator, a myopia management coordinator, help with organizing all of that so that the doctor can focus on patient care. Now back to the reasons for doing Ortho-K. I encourage us to look at the patient and see what they're ready for. They may have really dry eyes. Maybe soft contact lenses are not the best option for them at the time because they are playing water sports, for example. Or they might have dry eyes, or they might have really difficult time with insertion removal. So if they have a really difficult time with insertion removal, we'll start with a soft contact lens, and then within 1 month, sometimes they'll graduate to a hard lens and just be a lot more comfortable with them. But also take into account their hours of sleep. Is the child sleeping at least 8 hours a day? Ortho-K is most effective when children are sleeping 8 to 12 hours a day, 8 to 10 hours a day, but no more than 12. And the teenagers, like they stay up late at night and they don't get 8 hours of sleep. So by the time they're in high school and they have to stay up late to study for a final exam, it may be better to transition them to a multifocal soft contact lens at that time. But when they're really young and they have difficulty putting anything in their eye, we'll start off with atropine. Then we will try a multifocal soft contact lens because it's more comfortable, and they will graduate a lot easier onto a hard lens when they have tried the soft lens to begin with. Also taking into account their sports, their activities, their outdoor sports. Maybe they play water polo, or they're an active swimmer. They love jet skiing or dancing or doing karate. These are all activities that are better suited with Ortho-K than with multifocal soft contact lenses. So consider that. If the child is playing water sports or swimming, they don't want that soft lens to get chlorine in it or get cloudy when they are in the swim competition or irritate their eye. So Ortho-K is a much better lifestyle choice for the child. And so our mission is to provide myopia management services, and orthokeratology is one of the better ways of controlling myopia, but also it's better for the practice, it's better for the child. It's also better at reducing the risk for eye diseases. And we're improving the vision of the patients for life. So yeah, by reducing myopia in a child, they could end up being a minus 3.75 instead of a minus 9.75. And overall, that's going to reduce the risk for retinal detachment, for glaucoma, for myopic maculopathy, for posterior subcapsular cataracts. We recently saw a patient with minus 13.25 that needed cataract surgery, and she's only 40 years old. She had a posterior subcapsular cataracts. These patients, at a young age, we could have slowed down their myopia. Imagine seeing these patients 10 years from now and reducing their myopia by 60 to 70%. That's a win-win situation for everybody. So what's good for the patients is good for your practice. And this is my contact information. Thank you very much for your attention. Now we'll leave some time for any questions.
All right, Dr. Lui, thank you so much. Can you hear us okay?
Yes, I can hear okay.
Perfect. We do have a couple questions ready for your after your presentation, if you are good to go there.
Okay, great. Yes.
Perfect. Okay,
What
so
questions do you have?
yep, the first one we have is how often after beginning Ortho-K or myopia management do you measure axial length?
Oh, we tend to measure axial length every quarter, so every 3 or 4 months. It depends on the child. If they're younger, let's say from 6 to 12 years old when they start myopia management, then we typically do axial length measurements every 3 to 4 months. But if they're a little bit older, if they're 17, if they're 13, if they're like, let's say 15, 16, 17, or 18, in that case, we could measure every 6 months instead. It really is depending on the patient's case. And a lot of ways I kind of think of it as like glaucoma, for example. If somebody's retinal retina is changing really quickly, if their RNFL is getting really thin really quickly, then we would want to monitor with the OCT more frequently. But if everything looks stable at their target IOP, then we can extend out the measurements a little bit further out, like every 6 months.
Okay, perfect. Yeah, that makes sense. And the next question is when for consult scheduling, how long do your consults typically take?
They typically take somewhere between 10 to 15 minutes for the consult themselves, but sometimes that's if we have a comprehensive eye exam done already on the patient. If we don't have the comprehensive eye exam done completed ahead of time, then it could take 30 to 45 minutes.
Okay, so just patient dependent and if they're new to you or not.
Yes.
And you mentioned that you show the Ortho-K lenses during that consult visit. Do you also show them the insertion and removal tools as well and kind of what the process is for the patient at that time?
Yes. I mean, we may not show every single tool, but we show the majority of them. It's really easily available to us to show patients, and I kind of let the parents ask the questions and guide the discussion. So if they have a question about what their child sees, then we'll bring out the accommodative flippers. But it kind of like we don't need to show everyone every single tool, but we do use many of them routinely.
Okay. And let's see, I think we just had one more question here. And so the last question was, in the first year of a patient doing Ortho-K, how often on average do you follow up with that patient?
On average, every 3 to 4 months, if it's their first year. So if we're fitting them with Ortho-K for the first time, then we'll see them the next day. So we do a first morning follow-up. And then we see them again in about 1 to 2 weeks. And at that time, we'll see the majority of the corneal reshaping happening. And then we see them at 1 month. By then, we expect the cornea to take on the shape of the Ortho-K lens and treatment to be complete. At that point, we will follow up with their axial lens every 3 to 4 months.
Okay, perfect. Okay, so that was all of the questions that we had. If anything else comes through, we'll be sure to pass those along. And just as a reminder for everyone on the call, we will also post the presentation to Wave Academy for review if you need that in the future. And other than that, thank you so much, Dr. Lui, for attending tonight and preparing the presentation. That was great.
Thank you, Catherine. Thank you, Shelby. I want to extend a thank you to Sharon and Steve as well at Wave and the entire Wave team for all of your support.
Thank you so much. And with that, we'll go ahead and conclude tonight's presentation. And on behalf of Wave, have a good evening, everyone.
Thank you.